Good morning, everyone. I'm Alberto Galindo from Madrid, here in Spain, and I want to thank firstly the ISUOG and the chairs of this Fetal Cardiology Conference for this very kind invitation. I'm very proud of being among this top faculty in this meeting here in my country. And the first of my three talks that I have today is on one of the least, the rarest conditions among the big group of conotruncal defects as common arterial trunk, the prenatal diagnosis and management. This is, yes, one of the most uncommon conditions among the conotruncal defects. Let me put in presentation mode. Yeah. That is characterized by different parameters. The first one is that there is only one single arterial vessel arising from the heart that supports the systemic, pulmonary, and coronary circulations. And together with, there is only one great artery that in at least 40% of the cases arises equally from the both ventricles, from the right and to the left. In up to 40% of the cases emerges mainly from the right ventricle, and the remaining 20% of the cases emerges mainly from the left ventricle. There is one single semilunar valve that is called the truncal valve that most common has only 3 leaflets, but may have from 2 to 6 leaflets in this truncal valve. And this valve functions in most cases normally, but in up to 25% of the cases may be regurgitant or even stenotic. Another very common characteristic of this common arterial trunk is that in most cases there is no ductus arteriosus in up to 80% of the cases. And finally, there is a large single non-restrictive septal defect that is usually in the outlet septum, and the membranous septum is intact in most cases. So with these characteristics, it's easy to understand that it's very easy to differentiate this heart on the right side with a common arterial trunk from the heart that is the left side that is completely normal. Instead of having 2 equally sized great vessels that crosses the pulmonary artery emerging from the right ventricle and the aorta emerging from the left ventricle, we have only one vessel, one single large vessel that from which emerge the pulmonary trunk and then the aorta. So the differences are very pronounced, very obvious, and despite this, the detection rate of this condition is not 100%, and depending on the series that you can look at, the detection rate ranges from 40 to 80%. Let me remind you very simply the embryological basis of this condition. We all had, in the very beginning of our lives, in the first 4 weeks of pregnancy, a common arterial trunk. In the 5th week of pregnancy, the truncal swellings, together with the conal septum, divides this common arterial trunk in 2 equally sized great arteries, the pulmonary arteries that is connected to the right ventricle and the aorta that is connected with the left ventricle. And when these truncal swellings that do not form properly, we will have a common arterial trunk, persisting common arterial trunk. There is a leading role in the formation of this aortopulmonary septum, of the neural crest cells, and also of the second heart field cell that explain the close relationship that exists between this defect and the microdeletion 22q11, as we will see later. From the epidemiology point of view, this is, as I said you before, this is a not very common condition. Sorry. The incidence is 1 in at least 10,000 newborns. It represents about 1–2% of all congenital heart defects. In most cases, present isolatedly in 50 to 60% of the cases, and in the remaining cases may be seen associated with other defects, as we will see later. The risk of chromosomal anomalies is very high. ranging from 15 to 40%, mainly microdeletion 22q11, and the risk of non-chromosomal syndromes is also relatively high, mainly Charge, Emanuel syndrome, and so on. And the prognosis is usually good, especially if the common arterial trunk presents in isolation and in the absence of a dysplastic truncal valve, as we will see later. In these cases, the mortality situates around only 10%. There are different classification systems of this condition, but the most well-known are two that were described many years ago. The one from Colette and Edwards that goes from type 1 to type 4, and the one by Van Praag that goes from A1 to A4. The two most common forms are the first two types. The type 1 of Colette and Edwards classification, the type A1 of the classification of Van Praag, where we have is almost 50% of all cases of common arterial trunk, where we have a common arterial trunk, and this gives rise to the aorta, and there is a pulmonary trunk that gives rise to both pulmonary branches. In type 2 and 3, that belongs to type A2 of Van Praag classification, there is no pulmonary trunk, and the pulmonary branches emerges directly from the common arterial trunk, either from the lateral sides of the common arterial trunk or the posterior aspect of the common arterial trunk. Type 4, for many authors, is considered a type of pulmonary atresia ventricular septal defect with MAPCAS, as Professor Meger showed us in the past lecture. And finally, there are type A3, where the pulmonary branches emerges from either or the aortic arch and the other from the ascending common arterial trunk. And finally, one of the the most common forms is in where we have arterial duct. There is ductus arteriosus, and the aortic arch is either hypoplastic or even is interrupted. So I will show you in the following slides some examples of these types of common arterial trunk. From the prenatal diagnostic point of view, it's important to take into account that this condition should be looked for because the four-chamber view is normal in most cases. And we will see only a single and large great artery arising from the heart. There will be a large outlet ventricular septal defect that usually is not seen in the fourth-chamber view. The truncal valve is normal in most cases, but in up to 25% of the cases may be regurgitant and/or stenotic. And the pulmonary arteries usually arise from the left aspect of the common arterial trunk with a distance that is usually small but can be variable from the truncal valve. And this is very important in terms of surgery, as I will show you in my presentation. The duct is absent in most cases, and the aortic arch is on the right side in almost 1/3 of the cases. Let's show you some big clips. This belongs to type 1. This is the more common type. You see a normal four-chamber view, and we see here a large VSD and only one vessel arising from the heart. This is the truncal valve. This is the common arterial trunk. This is the aorta, and we have here a pulmonary trunk. This is the pulmonary ostium connected to the common arterial trunk, and we have here the two branches, the left branch and the right branch emerging from this pulmonary trunk. This is one example at 20 weeks of pregnancy of one common arterial trunk type 1, which is by far the most common. If you see some of these images, you can compare this with the tetralogy of Fallot that Professor Meger showed us before, but you have the key is to see that there is no pulmonary trunk connected to the right ventricle to differentiate this overriding, these large vessels that overrides over the septal defect to differentiate this condition from the tetralogy of Fallot. Here there is no vessel arising directly, or the pulmonary artery is not connected to the right ventricle to differentiate this from the tetralogy of Fallot. So this is very important to take into account. Another examples, you here see another example of type 1 or A1. Here, this is the common arterial trunk overriding the septal defect. And there is a large vessel, large single vessels, and here is the pulmonary artery, and here are the branch, the left branch, and the right branch and the left branch. And we always have to look how this common arterial trunk feels, how the blood flow goes through the truncal valve to see the valve is stenotic or regurgitant. This is very important, as we'll show you before, from the prognostic point of view. Here in the slow motion to see the movement of the truncal valve, and to see now with color Doppler how the truncal valve, the blood flow through this truncal valve. This is a normal flow, but there is a mild regurgitation of this truncal valve. Another example of a larger baby, you see a normal four-chamber view. You see a great vessel arising from the heart, overriding the septal defect, quite similar to what's seen in tetralogy of Fallot, but here the difference is that the pulmonary artery is not connected to the right ventricle. The pulmonary artery is connected to the common arterial trunk. There is only one single semilunar valve, the truncal valve, and not two valves as is in tetralogy of Fallot. And we have here the two branches, the right branch and the left branch of this type 1 common arterial trunk. And once again, we explore with color Doppler how the trunk feels from receiving blood flow from both ventricles. That explains also why this large single vessel is so large. This can be detected in the first weeks of pregnancy. This is a transvaginal scan of baby with common arterial trunk. Type 1 or A1 is the same thing, and there is only one large vessel arising from the heart, mostly connected to the right ventricle, and that occurs in 40% of the cases. And we see with color Doppler how it feels, and there is a huge regurgitation of this truncal valve. That this is very important from the prognostic point of view. Another example on the right side, also in the first half of pregnancy, the baby with, you see, once again, a normal four-chamber view, and this large vessel arising mainly from the right ventricle, and you see here the aspect of this truncal valve. This is quite dysplastic, very thickened and hyperechoic truncal valve. And you see a large vessel and the pulmonary trunk here arising from the left lateral aspect of the common arterial trunk. These are all examples of type 1 common arterial trunk. Type 2, there is no pulmonary trunk. The pulmonary branches arise directly from the common arterial trunk, usually from the posterior aspect of the common arterial trunk. You have to look for these branches to see when they are connected to the common arterial trunk. Usually they are very close one to the other, and here is on the posterior aspect of the common arterial trunk. You see here the left branch, this is the left aortic arch, and here is the right pulmonary artery, but there is no pulmonary trunk in this baby. Another example, quite the same thing. There is no pulmonary trunk in this baby. You see now, once again, the normal four-chamber view with a persistent left superior vena cava. And we have, once again, the large septal defect and the one large vessel arising from mainly, in this case, from the left ventricle, and we have here the two branches emerging from the posterior aspect of the common arterial trunk. Type 3 is quite similar to the previous one. Here, the pulmonary branches arise from the lateral aspects of the common arterial trunk, so it's sometimes very difficult to differentiate type 2 from type 3, but here the pulmonary branches usually are very close together, emerging directly from the common arterial trunk. Here we have a right aortic arch, and here is the the right branch, and here is the left branch. Another example of type 3, you see once again that the four-chamber view is almost completely normal in these babies with this condition, common arterial trunk. Now the pulmonary trunk, the common arterial trunk is connected mainly to the right ventricle, and we have here the branches arising from the lateral aspect of the common arterial trunk. These are all postnatally confirmed diagnoses in this case, of type 3 common arterial trunk. Professor Merger showed us previously this same thing that I told you quickly. There are many authors that do not include type 4 common arterial trunk inside this condition because many consider as a type of ventricular pulmonary atresia septal defect with MAPCAS, but it is true that there are also some differences between these conditions because you have here a baby that has one single vessel arising from the heart, and you will see here is the right pulmonary branch emerging from the descending aorta in blue color. You can see here this vessel, this small vessel coming to the right lung from the descending aorta, and here is you will see now the left pulmonary artery emerging from the ascending aorta. So this, for us, we gave the diagnosis, the prenatal diagnosis of type 4 common arterial trunk. But it is true that it's very difficult to differentiate this from MAPCAS because here we have here a baby with a diagnosis of pulmonary atresia septal defect and major aortopulmonary collateral arteries, and there are many similarities between these two conditions. You will see many vessels arising from the aorta, either from the ascending and the descending aorta as well, filling the lungs. So probably the number of vessels is a clue to the number of vessels filling the lungs can be a clue to opt for pulmonary atresia septal defect with MAPCAS when you see many vessels. And when you see only 2 vessels, probably is a key argument to establish the diagnosis of common arterial trunk, but we can discuss it later on. Another point is that if there is a pulmonary atresia conceptual defect and MAPCAS, we will see retrograde flow through the ductus arteriosus that is usually absent in common arterial trunk, as I said you before. And the rarest form of common arterial trunk, but the most, but this is a very characteristic picture. You see another normal four-chamber view, but you see there is only one vessel arising from the heart. But from this vessel, you have firstly the aorta and then the pulmonary artery, but there is arterial duct. So you may have only having one vessel arising from the heart, a close to normal 3 vessels and trachea view, as you will see in this same video clip, because there is arterial duct that he's connecting with the aorta. So you will see with color Doppler an almost normal 3 vessels and trachea view. You have here, this is the aorta, and this is the duct and the pulmonary branches. This is usually seen when the aortic arch has hypoplastic or even interrupted, which this is the case on the right video clip. You will see this is the aorta, this is a small aorta. Okay. And here is the arterial duct. This is larger than the aorta. So it was only one vessel arising from the heart. And this is the type A4 of common arterial trunk. And with color Doppler, we will see a close to normal 3 vessels and trachea view. This is an stenotic truncal valve, as you see the turbulence of the blood flow through this truncal valve. And we have here the 3 vessels trachea view in a baby with common arterial trunk, and the same on the right side. In terms of making differential diagnosis of common arterial trunk, I have said you before, the first condition is with pulmonary atresia and septal defect. Here, it's very important to see the reverse flow in the arterial duct, because this is a clue for establishing the diagnosis of pulmonary atresia with septal defect. Remember that in common arterial trunk, usually there is no duct. So if you see reverse flow in the arterial duct, probably is pulmonary atresia with septal defect. And the other condition that should be differentiated for common arterial trunk is aortic atresia with ventricular septal defect. In this baby, this is a very uncommon condition, but when there is a large septal defect, both ventricles are almost equally sized, and you see only one large vessels arising from the heart, which is the pulmonary artery, because there is aortic atresia, but there is no hypoplastic left ventricle. So in these cases, the diagnosis can be made looking at the flow in the aortic arch that will be reversed coming from the arterial duct. Once again, here the color Doppler is very useful to establish the diagnosis of aortic atresia with VSD and not common arterial trunk, although you are only seeing one large artery arising from the heart. This is a large VSD that allows the filling of the left ventricle together with the mitral valve flow. Given these similarities, it's not strange to have some discrepancies between the prenatal diagnosis and the final postnatal diagnosis. We look at our own experience. We analyzed the results of 55 fetuses with common arterial trunk diagnosed prenatally, and we have a very good diagnostic accuracy, but in 50 cases, the postnatal diagnosis almost agreed completely with the prenatal diagnosis, but 5 cases in which we established the diagnosis of common arterial trunk were postnatally diagnosed of having pulmonary atresia with VSD, 2 cases of aortic atresia with VSD, and 1 case of double outlet of the right ventricle. And for the type of truncus, we also were very good in terms of accuracy, but in 4 cases, the final postnatal diagnosis differed slightly from the prenatal diagnosis. The overall diagnostic accuracy was, anyway, very good. Our early mortality, in our experience, was 10% for isolated cases, but rose to 27% for non-isolated cases. And looking at prognostic markers of mortality in isolated cases, we observed that the most important parameter to predict mortality in isolated cases in our experience, and this correlates well with the experience of other groups, was the anatomy and the function of the truncal valve. That's why it's very important whenever you see a common arterial trunk to assess the blood flow through the truncal valve to see if the valve functions normally or not. In the left side, you may see a normal truncal valve, and on the right side, you may see this plastic truncal valve. You see thickened and very hyperechoic that does not completely open in systole. And when you put the color Doppler, you may see this turbulent flow through the truncal valve. You must think that this truncal valve will be the aortic valve when this baby is repaired after birth. So if the systemic semilunar valve is an abnormal valve, probably the baby will have many complications after surgery. So that's why it's very important to look for always the function of the truncal valve. What parents must know about this condition? We must say them that in many cases there are associated anomalies, and therefore it's very important to do a thorough survey of the complete fetal anatomy. We always have to offer invasive testing for rule out chromosomal anomalies that are present in many cases. But in isolated cases, the parents must be reassured because the prognosis is usually very good. It is possible to do a complete repair of this condition and to repair the truncal valve and even the aortic arch. And looking at the data, the largest series that we have so far is the data from the European Congenital Heart Surgeon Association, where are many, many centers, including their numbers for up to 90 countries. And we have many, more than 1,000 patients included with common arterial trunk, and the 30-day mortality was at around 12%, and the hospital mortality at around 14%. So for isolated cases, this is the numbers that are currently reported in many centers around the world. And the long-term outcome is usually also very good, although the truncal valve dysfunction is probably the main risk factors. These babies should be followed up until birth, up to 4 to 6 weeks echocardiogram. Truncal valve should be monitored, as I said to you before. And these babies always be delivered in tertiary care referral center with cardiac surgery facilities. Usually, they undergo surgery in the first 2 months of life, where a surgical complete repair is done or is made. And sometimes, when the pulmonary artery arises very close to the truncal valve, the surgeon can connect directly the pulmonary artery with the right ventricle, and therefore it's not necessary to use a conduit between the pulmonary artery and the right ventricle, and therefore it is not a conduit is not placed in the heart of this baby will not need additional procedure to replace the conduit. So this is very important. This is the Barbero-Marcial procedure, where the pulmonary artery is directly connected to the right ventricle. Sometimes these babies need, before the complete repair, additional procedures, especially when there is severe pulmonary stenosis, and this baby may need a modified blood octasis shunt in the first weeks of pregnancy. And sometimes, when there is no mild, when there is no pulmonary stenosis, or is only mild, and there is increased pulmonary flow to the lungs, this baby may need either medical therapy or abandoning of the pulmonary arteries before the complete repair. And in some cases, these babies will need additional procedures to replace the conduit or replace the truncal valve in case that it not works properly. So to conclude, my take-home messages are the following. Common arterial trunk is a rare but easy to detect prenatally condition because there is only one artery arising from the heart. However, the fourth chamber view is normal in most cases, so this is a condition that you have to look for, because the fourth chamber view will not say you that there is a heart defect in this baby. Up to 40% have associated cardiac or extracardiac anomalies, and it is very important to know. Up to 30% have associated chromosomal or single gene disorders, and therefore genetic assessment is also very important. Associated condition and truncal valve dysfunction are the most important prognostic factors. This baby should be delivered at tertiary care referral centers, where survival rates at around 90% for isolated cases are currently reported. And finally, corrective surgery for this condition is possible, having biventricular circulation. However, these patients will need, most of them, additional procedures later on, for example, to replace the conduit between the right ventricle and the pulmonary artery, and or for reoperation over the truncal valve. And that's all. Thank you so much for your attention.